So we was on the question number 7. By the end of the first period of the physiological labor, clear amniotic fluids came off. Contractions lasted 35 seconds to 40 seconds every 4 to 5 minutes. Heartbeat of the fetus was 100 bpm, and that is less. Then BP was 140, that is more. So what is the most probable diagnosis? देखो, in case of when we talking about the physiological labor or whatever, this intranatal hypoxia, this is the common things that we seen in the children's. So this intranatal hypoxia, it can be due to malocclusions of the uterus, intranatal hypoxia or the intranatal hypoxia or hypoxia. It is very common. Hypoxia, it is common after the delivery or after abortions. Common after the delivery and abortion. After the delivery or abortions. So this can be due to prolapse, uterine prolapse. There is something that we call uterine prolapse. There is something called the occlusion of the umbilical cords. So if the occlusions, the umbilical cords that becomes occluded, that have some obstructions, you can remember. There can be some obstruction, so that can also be the reason. So occlusions of the umbilical cord can be there. Placental infarctions can be there, the maternal diabetes can be there, maternal smoking can be there, and the post-term pregnancy can be there. Some student messaged me on the YouTube today. ठीक है, कमेंट ऑन द यूट्यूब व्हाट ही सेड कि 1 घंटा 11 मिनट की वीडियो में सिर्फ क्या कराए हैं, 4 क्वेश्चन कराए हैं, इतने में तो आपका ही सुनते रहेंगे क्या? तो आपका ही सुनते सुनते तो हमें मतलब वो 170 क्वेश्चन करने हैं, तो वो कैसे होगा? तो वो उसके बाद मैंने उसको रिप्लाई करा, जो मैं आपको डेली बताता हूँ कि हम 4 क्वेश्चंस नहीं करते हैं, वो आपको पता है। उसके बाद उसने तुरंत हाइड कर दिया। तो अभी मैं क्या करूंगा, वो उसने बोला कि वर्बली पढ़ाना है, तो मैं वर्बली पढ़ाऊंगा, ठीक है? तो उसके अकॉर्डिंग वो स्लो था, और अभी तुम इतने में बोल देते हो कि फास्ट है, ठीक है? सो वी विल सो रिमेम्बर दिस थिंग्स, ठीक है? तो यू विल बी कंप्लीटेड एवरीथिंग, वी कवर्ड द ऑल द टॉपिक्स, ठीक है? एंड आफ्टर दैट द क्वेश्चंस विल बी इजी. So this is the intranatal hypoxia common after the delivery or abortions. It can be due to prolapse, occlusion of the umbilical cord. If umbilical cord is occluded, so that will be the intranatal hypoxia. Then after that there will be the maternal diabetes. There can be the maternal diabetes also can be there. Maternal smoking can be there. Post-term pregnancy can be there. Okay. So these all are the reason of the hypoxia. Then after that, like what are the signs we will see at the time of the birth? The signs of hypoxia at the birth. The sign of hypoxia at birth. So what the signs? Like there will be the blue skin or pale skin will be there. The blue skin or pale skin will be there. After that, we can see there is a lower heart rate will be there. There will be the lower heart rate will be there, and muscle tones will be decreased. Muscle tone will be decreased. The muscle tone will be decreased, and also remember there will be the reflex will be also decreased. The reflex will become poor. Sorry. The reflex will be poor, and there is a problem in the breathing also. So the breathing difficulty will also be seen. Okay. So the sign of hypoxia at the birth, there is a blue skin or the pale skin, there is a lower heart rate, muscle tone decrease, reflex will be the poor, and breathing difficulty will be there. By the end of the first month, if any, like after the physiological labor, this is a very common thing that we see in the case of the fetus. In the fetus, what are the signs we will see? The heart rate will be lower, muscle tones will be decreasing, blue skin or the pale skin due to low oxygen supply, and the reflex will be poor, breathing difficulty will be seen. Also, there can increase the blood pressures as well in the children. So like metabolic abnormalities will be there. Because, and also remember if any diabetic condition also, the maternal diabetes also, so that can be the reasons, and diabetes is associated with the hypertensions. Okay, the diabetes condition is associated with the hypertension in the pregnant lady. That's why this will see acute hypoxia of the fetus. What we will see, that acute hypoxia of the fetus. Here in this question, heart rate is decreasing and the blood pressure is increasing. Okay, so that you need to remember. What are the about how many contractions and everything we will discuss in the labor parts. Then this question, a pregnant woman in her 40th week of pregnancy undergo the obstetrics examinations. The cervix of the uterus is developed. The oxytocin test is negative. Examination at 32 weeks revealed AP is 140/90. Proteinuria is there. Peripheral edema is there. Reflexes are normal. So choose the correct most tactics. So as we can see in this question, that this question will be having, in this question what we are seeing, that this patient is having the blood pressure is high, so the patient is hypertension. Along with that we are seeing that this patient is having the proteinuria and edema. So if the proteinuria is there, edema is there, so in that conditions what we will see, you already hear that terminology. What is that? Pre-eclampsia conditions. There is two conditions when we having the pre-eclampsia and another one is the eclampsia. So when we talked about the pre-eclampsia condition, so it is associated with the proteinuria and along with that there will be the hypertension. But eclampsia, what we will see, the seizure. So let's discuss that one another topic for today, that is the pregnancy induced hypertension. Pregnancy induced hypertension. In case of, or we can call it the PIH, the pregnancy induced hypertensions, or PIH. Pregnancy induced hypertensions, what we will see, there can be the gestational, hypertension, will be there. And when we talk about the gestational hypertensions, so gestational hypertension is only, why it's roaming either there. The gestational hypertension, there will be the only hypertension. What we see, only hypertension will be there. And in case of the pre-eclampsia, pre-eclampsia conditions, so hypertension will be there. Along with the hypertension, what we will see, we see there is a proteinuria. Will be there. There will be the proteinuria will be there. So always remember, when we talk about the gestational hypertension, so if there is a increase in the BP, blood pressures, after 20 weeks of pregnancy, so we call this condition as the gestational hypertensions. And these gestational hypertensions, which will become the normal within the 12 weeks after the delivery, will be normal after 12 weeks of delivery. And we will check on the 2 occasions 4 hours apart. On the 2 occasions 4 hours apart, we will check these conditions. And if we see that there is a normal blood pressure, so we can consider, okay, this is what gestational hypertension. It increases after the 20 weeks of pregnancy and will be normal after the 12 weeks of the delivery. And we will check for the on the 2 occasions 4 hours apart. Like for example, if we checking at 8 a.m. in the morning, so after that again we will check after the like 12 p.m. or 1 p.m. And but in pre-eclampsia there is a hypertension, there is an increase in the blood pressures, as well as there you can see there is a proteinuria also will be there. And hypertension, that is the better reliable marker of what? Pre-eclampsia. In pre-eclampsia the hypertension will be there, but in the proteinuria it can be the less, it can be the more. So that's why if any female, like if any female comes or any lady comes with presents with the blood pressure is 150, for example 150/90 mmHg at 34 weeks of pregnancy, so what will be the next step? You will do? So you will check the proteinuria conditions, because preeclampsia, this is the most commonly seen in case of the pregnant lady. So the next step, 34 week pregnant. So the next step will be the, you will check the urine dipstick test. Urine dipstick test, and we also called it as the protein test. So protein test will be done to check the about the proteinuria, And remember the best method for evaluation, so that will be the best method for evaluations will be the 24-hour urinary protein. The 24-hour urinary protein, that will be the best method for evaluations, that will be there. Okay. And what is the cause of the preeclampsia? The cause will be that is the inadequate trophoblastic invasions. Now just hear these things because this is not the important for the exam. So normally what happen, there is some extravillous cytotrophoblast is there. The extravillous cytotrophoblast, especially we can call it the there is an endovascular cytotrophoblast that lining the spiral vessels. For example, if we having the spiral artery here, we having one artery there, that is the spiral artery, and this spiral artery, that is what replaced by the endovascular cytotrophoblast. So when there is a inadequate trophoblastic invasions, so there will be the vessels will become rigid and blood flow to the placenta will be decreased. And after that, if blood flow to the placenta decrease, there will be the placental ischemia. If ischemia will be there, there will be the inflammatory mediators, and those inflammatory mediators, they will cause the blood stasis, and blood stasis, there will be the platelet aggregation and all those things, and finally there will be the end organ damage will be seen. So you can remember the one line here, that what is the cause. The cause, maybe you will get some hint in the questions, but you will not get this question directly. What is the cause of the preeclampsia? Then you can remember it will be the inadequate trophoblastic invasions. Just remember this line, inadequate trophoblastic invasions will be there. Okay. What will be the risk factor? Mainly the primary. What is the primary? Means first pregnant lady, the lady who is having the first pregnancy. Then there is a new paternity, new paternity, that is new father, that is the or we can have the primary also. Then if there is a twin, like two placenta is there, so two placenta, again there will be the compromise of the bloods, the placental ischemia and organ damage, that will further lead to the hypertension, all those things. There is one more thing, that RH incompatibility. In RH incompatibility, there is an increase of what placental size will be there. There is increase of the placental size. Then there can be the molar pregnancy. So all these can be the regions. From here, you need to remember most probably the primary and the new paternity. They are the major risk factor that we seen in case of the pregnancy induced hypertension or the preeclampsia conditions. Okay, that you need to remember. Dekho, preeclampsia, if we talk about the preeclampsia, there is three things that we need to remember. The one, we having the early onset. The early onset, we see that will be the 20 week to the 34 weeks. Then there will be the preterm or late onset. And the preterm or late onset will be at because it is the preterm, so before the 37 weeks, so it will be 34 to 36 weeks. We call it the preterm or the late onset. And there will be the term onset. It can be the term onset, if the preeclampsia develop after 37 weeks, we call it as the term onset. Okay, so that you need to remember. The other questions, that is the I think in the test center website also you will get 2 to 3 questions. That what are the types of preeclampsia? What are the types of preeclampsia? The types of preeclampsia will be there. Then the types of preeclampsia, so let's discuss. So there can be the mild preeclampsia. There will be the mild preeclampsia. The mild preeclampsia will be there. The mild preeclampsia, it will be without any severe feature. Means there is no severe clinical features you will see. This is without severe feature. So we call that the mild preeclampsia. If because focus on this topic, because this is a quite confusing topic also, that you will keep forgetting. Okay, so mild preeclampsia, you need to remember the value also. The systolic blood pressures will be less than equal to 140 mmHg, less than equal to the 140 mmHg, and the diastolic blood pressures will be equal to the 90 or more than equal to 90 mmHg to less than 1110 mmHg. So this one you need to remember, 140 by 90, 140 by 90 or 90 to 110. So that is the mild preeclampsia. In these conditions, what we will see, the proteinuria. What we will see, the proteinuria will be there, and the proteinuria will be more than equal to 300 milligram per 24 hours, or we can say the less than 5 gram per 24 hours. It will be in grams, that less than 5 gram per 24 hours. Then we will check this again on 2 occasions 4 hours apart. We will check on the 2 occasions 4 hours apart will be checked. On 2 occasions 4 hours apart. When we do the dipstick test, so in the dipstick test we see the 1 plus to 3 plus will be the proteinuria conditions will be there, and the urine protein or the creatinine ratio will be checked also in these conditions. But that you need to remember here, the most importantly you need to remember the blood pressures value. The blood pressures value will be less than 140 by 90, and diastolic pressures will be more than 90 or less than 110 mmHg. The another one, that is a severe that will be the severe preeclampsia. If this is the severe condition, if the severely conditions, so in the severe condition what we are seeing, this hypertension will be there or proteinuria also will be there, but here also we will see the hypertension plus proteinuria with severe feature or the severe clinical features. Like for example, we can say the end organ damage also possible in this case, that's why it becomes the severe. Now also remember the value here, that systolic blood pressures will be more than equal to the 160 mmHg, more than equal to 160 mmHg, and diastolic blood pressures will be equal to the more than 1110 mmHg. Okay, so remember the one value 140 by 90 110. Okay, and here more than 1110, more than 160, that will the systolic blood pressures, and diastolic blood pressures more than 1110. And if we talk about the proteinuria, as what I told here, that is the more than 300 milligram per 24 hours, or we can say less than 5 gram per 24 hours, less than 5 gram per 24 hours will be seen. Then if here in these conditions, if we talk about that more than equal to 5 gram per 24 hours will be their proteinuria. And dipstick test, what we will see, 3 positive. Dipstick test, what we will see, more than 3 positive will be the dipstick test will be theirs. Here what we will do, we will check on 2 occasions, but it's not 4 minutes apart, it is the 50 minute apart. We will check the 50 minutes apart, because the blood pressure is high, diastolic blood pressure is high, so there is a chances of more organ damage. So the most common features that we can see, it can be possible, it not be possible, that is the end organ damage. Because in the severe conditions we know, if you have the more hypertensive conditions, so in the more hypertension condition there will be the chances of the end organ damage will be possible. What the severe features we will see, or the severe clinical features? What is the severe clinical features we will see? So in this patients we will see there is a headache, and this headache will not relieve. The patients will give the history that doctor, I take the some painkiller also, but my headache is not properly treating. There is no relievement in my head, so there is a not relieved by analgesics. So that is the headache, not relieved by analgesics, not relieved by the analgesics. Then there is a decrease in, then there will be the decrease in vision will be there. There will be the decrease in vision will be there. There can be the scotoma also. There can be the scotoma also. There can be the diplopia also. There can be the diplopia also, and there can be the blurring of the visions also be possible. The blurring of vision will also be possible. So severe clinical features, what you see, the headache that is not relieved by analgesics, that is decrease in the vision, scotoma, diplopia, and the blurring of the visions will be seen. Okay, that you need to remember, because all this history you will get in the questions, and you will get the, there is a both options, mild preeclampsia also and the severe preeclampsia also in the options. Okay. And also they can ask you if the end organ damage, the most common or the first organ that damaged, the most common or the first organ that damaged in preeclampsia, that is the kidney. The most common or the first organ damaged, that will be the kidney will be damaged. Okay, that you need to remember. And also remember, if we talk about the first clinical manifestations, the first clinical manifestation in case of the PIH, what will be the answer? First clinical manifestation in PIH, so that will be the hypertension. That will be the hypertensions. If we talk about, there is a first hematologicals, there will be the first hematological manifestation in PIH. Manifestation in PIH, first hematological manifestation PIH, so that will be the thrombocytopenia. That will be the thrombocytopenia will be there. Thrombocytopenia will be there. Okay, देखो, see, as the preeclampsia, it is started with the mild preeclampsia. It is started with the mild preeclampsia, and now this mild preeclampsia will be converted into the severe preeclampsia. It will convert into the severe preeclampsia. If you will not able to treat the severe preeclampsia, this severe preeclampsia will convert into the HELLP syndromes. There is one syndrome we call the HELLP syndromes. If we will not able to treat the HELLP syndrome also, then it further complicated and it become the eclampsia. Now you understand why we was doing the urine dipstick test. Because if the patient is having some proteinuria and preeclampsia condition, that patient is more prone to the eclampsia. And in eclampsia you will understand, because in eclampsia what we see the seizures. What we see, the seizures type of the things. That's why we see that we need to take the next step, that will be the urine dipstick test will be there. If you having the patients, and who is like undergoing the mild preeclampsia conditions, so for the mild preeclampsia conditions, we will monitor the patients till 37 weeks. We will monitor the patients till the 37 weeks. Then after the 37 weeks, what we will do, we will do the induction of labor. We will do the induction of the labor will be done. If the patient is severe preeclampsia patient, so in that conditions, what we will give the drug of the choice, that is the labetalol. Labetalol is what? Beta 1 blocker. and they also block the alpha. So it is alpha and the beta blockers. Plus this is all we will give the steroids. Steroids 28 to 34 weeks, because lungs are not mature at these times. 28 to 34 weeks lungs are not mature, so for that we will give the steroids. Plus we will monitor the patients. Till 34 weeks. We will monitor the pill 34 weeks, and at 34 weeks what we will do? Induction of labor. Induction of labor will be done. Induction of labor means we will induce the labor. We will induce the contraction. So that is the induction of the labor will be there. Okay. If mild preeclampsia, we will monitor till 37 weeks. We will monitor till the 37 weeks. If the severe preeclampsia, we will monitor till the 34 weeks. Monitor till 34 weeks, and then we will do the induction of the labor. Okay. What is the final management or the definitive management in this condition? That is the induction of the labor, because finally what we are doing, we are inducing the labor by ourselves, or we are terminating the pregnancy at 34 weeks and at 37 weeks in both conditions. Okay. Then the next one is what? That is the HELP syndrome. What is the HELP syndrome? HELLP. What is the HELP syndrome? See, in case of the HELP syndrome, what we are seeing, there is a HELLP. So H4, there will be the hemolysis. This hemolysis due to hemo concentrations. Then there will be the EL. There will be the elevated liver enzymes will be there. And LP means there will be the low platelets will be there. The low platelets level will be there. Okay. The hemolysis, it will be due to hemo concentrations. Hemolysis will be due to hemo concentrations, and elevated liver enzyme due to hepatic hypoxia. The low platelets level will be due to platelet aggregation. The platelet will become aggregation, as when I was telling you. So I told you that there is some platelet problems will be there, and the platelet aggregation, the platelet ischemia. So in case of the HELP syndrome, the platelet accumulation that will lead to the platelet count will be reduced. So there is a low platelet will be there. And the most commonly what we see, the acute pain. We see the acute pain where in right hypochondrium, the acute pain in right hypochondrium or epigastriums. So remember these things. Acute pain in right hypochondrium or epigastrium will be seen. And for this HELP syndrome, we follow the tennis criteria. We follow the tennis criteria. In the tennis criteria, if the platelet is less than 1 lakh, LDH will be twice than the normal, and the liver enzymes again will be twice than the normals. So that will become the tennis criteria. So just remember the names in the HELP syndrome, which criteria we use, that is the tennis criteria. I think management is also not important for you. So if the gestational age is less than 34 weeks, we will give the steroids and then we will deliver. If the gestational age is more than 34 weeks, then what we will give the magnesium sulfate management. If there is a less than 34 weeks, so in that conditions we will give the steroids and then deliver. Give steroids and deliver the baby. If more than 34 weeks, if more than equal to the 34 weeks, so in that conditions we will give the magnesium sulfate, because HELP syndrome is very near prone to the eclampsia, and in eclampsia what we see, the seizures. So we will give the magnesium sulfates to prevent the seizures. Along with that, we will give the labetalol also, and we will finally what we will do, the termination of the pregnancy, that the IOL, induction of the labor will be there. The next important point for your exam is eclampsia. The next important point for your exam will be the eclampsia. Where my phone? Eclampsia. देखो in case of the eclampsia, what is there? There will be the severe pre-eclampsia. There will be the severe pre-eclampsia will be there, plus what we will see, the convulsion will be there. The convulsion or the seizures will be seen. The convulsions or the seizures will be seen, and this convulsion or seizures will be due to cerebral hypoxia. The cerebral hypoxia will be there, and due to which what we see, the convulsion or the seizures, and that is the dangerous things in these conditions. So that's why we need to prevent the eclampsia before only. Okay. And this eclampsia conditions we normally seen in case of the antepartum condition only, and that become the worst prognosis with and that's why we need to prevent this as early as possible. For the management, remember, whenever the seizures come, the convulsions comes, the first thing should come in your mind, what the first management? Can anyone tell me what the first step or the first management you need to do in case of the convulsions or the seizures patients? Primary means primary gravida, है ना, प्राइमी पैरिटी, ठीक है, समझ में आया? प्राइमरी ग्रेविडा मतलब प्राइमरी मतलब फर्स्ट डिलीवरी, फर्स्ट टाइम, शी वाज फर्स्ट टाइम प्रेग्नेंट, सो वी यूज द प्राइमी. डायजेपम एयरवे मैनेजमेंट, हमजा हसन्स एयरवे, ABC. So Kalagi is right, what we do, and all you are right, what we do the first management. So the first management will be always, the first step or the first management will be always the airway management. There will be the airway management. Whenever the seizures comes, make the try to open the airway of the patients, because that is the biggest problem that we seen in this patient. There will be the problem in the airway because of the there will jaw claudications will be there. Now we will, after that, when we will maintain the airway, the second things what we will do, we will give the drug of choice. And what the drug of the choice to prevent and treat the eclampsia? This one you already know from your Crocono point of view, that is the magnesium sulfate. And the drug of the choice to control the blood pressures, what is that? We will give the labetalol to decrease the blood pressure. After that, they do the immediate induction of labor. Whatever, irrespective of the gestational age. So immediate induction of the labor irrespective of gestational age. Whatever the gestational age, you need to do the induction of the labor will be theirs. Okay. Now, whenever you are giving the magnesium sulfate, there is one terminology that we studied in case of the pharmacology, that is the therapeutic index. Whenever the therapeutic index means, this is the narrowest range. Will be there. So this is the range. We can say not the narrow, but this is the range at which we will give the dose to the patients. If the dose if we will increase the dose, then it will be problem. If we will decrease the dose, then also it will be a problem. So for magnesium sulfate also, it having the narrow therapeutic index. It will having the narrow therapeutic index. It having the 4 to 7 milli equivalent per liters. 4 to 7 milli equivalent per liters. Okay. And also remember, magnesium sulfate, they act on the NMD receptors, and in NMD receptors they will cause the vasodilations. They also block the calcium channels. So for magnesiums, what you need to do, if you are giving the at higher dose, so it will become the toxicity. And the toxicity, the earliest what we will see, The earliest toxicity, like if the patient is taking the magnesium sulfate or we give the patients magnesium sulfate, the toxicity or the side effect we see in case of the magnesium sulfate, we will see there is a disappearance of the knee jerk. The disappearance of, this is the high yield point. If you want to remember, you remember, otherwise leave it. There is a disappearance of the knee jerk will be there. The disappearance of the knee jerk will be there, and it will be at 10 milli equivalent per liters. Then there will be the at 12 milli equivalent per liter. At 12 milli equivalent per liter, what we will see? We will see there is a respiratory depressions will be there. There will be the respiratory depressions will be seen. Then there will the toxicity. So the toxicity at 15 milli equivalent per liters. At 15 milli equivalent per liters, what we will see? We will see there is a respiratory arrest. There will be the respiratory arrest will be there. The magnesium sulfate, the toxicity. This is the earliest toxicity at 12 at 15. So disappearance of the knee jerk, respiratory depression, and respiratory arrest. So that's why the magnesium is given under control, because of its narrow therapeutic index. If you want to remember this, remember this. If you want to forget this, forget this. Don't worry, it will not come in this exam, because this is important for other exams. So that's why I'm saying this is the important. Okay. And also, if you will further keep increasing the dose, like for example at 30 milli equivalent per liter, that will become the, it will cause the cardiac arrest. It will cause the cardiac arrest will be theirs. Okay. What the okay? Tell me what is the antidote? This was your question. Sorry. Magnesium antidote is the calcium gluconate, and calcium gluconate will be the antidote, and we will give the IV. Or the drug of the choice. To tell me what is the drug of the choice to treat the preeclampsia conditions? This is the question also. The drug of the choice to treat preeclampsia, and your options are labetalol and alpha methyl dopa, or both. Both are correct. Labetalol, methyl dopa, labetalol, methyl dopa, or both. Both. Okay, so both are the correct answer. So both are the correct answer. The labetalol is the drug of the choice to treat the preeclampsia more than the alpha methyl dopa. The first we will give the labetalol, and after that, if the labetalol is not available, we can give the alpha methyl dopa will be answer. Okay. ठीक है यहाँ तक? This is okay. Okay, there is one, I think you have the one question I think about the supine hypotension syndrome. Supine hypotension syndrome. देखो, there is a supine. Supine, you know that woman is sleeping at the supine position. Okay, the supine position, hypotension syndrome. So this is the good predictor of the PIH. Good predictor of PIH. We call this test as the chain rollover test. What happen in the supine hypotension syndromes? When the normally what happen when the woman, it turns from lateral positions to the supine positions. So her blood pressures what will be decrease. Her blood pressures will be decreased. देखो, woman is sleeping where? How? When lady turns from lateral positions to supine positions. Lateral position to the supine positions. So देखो, whenever she will be on the supine position, so below that there with the, they see baby having the uterus, and in the uterus you have the fetus is developing, and this fetus will compress the inferior vena cava, and when this fetus will compress the inferior vena cava it will be compressed at the supine position. So there will be the decrease in what? Blood pressures. That we called it the hypotension. That we call the hypotension. Okay. So supine hypotension syndrome. So become the supine hypotension syndromes. Okay. Supine hypotension, we call it the supine hypertension syndrome. So that is the decrease in what? Blood pressure. So we advise the lady that she should having the sleep on the towards the lateral position, so that's the IVC will not be compressed. भगवान सुना दो पहले ही रखा. Okay, so this was what about the supine hypotension syndromes. ये बंद करना. Supine hypotension syndrome. देखो, in supine hypotension syndrome, if we talk about the predictor, so this is the normal conditions we seen in case of the supine hypotension. If you talk about the predictor of the PIH, so that will be the supine hypertension syndromes. Make it supine hypertension syndromes. Okay, and this is what? This one is the supine hypotension syndromes. Supine hypotension syndrome. So this is the normal condition that we seen in case of the pregnant lady. Nor usually we will see that when the lady will turn from lateral positions to the supine position, so there the compression of the inferior vena cava, due to which blood pressures will be decreased and there will be the hypotensions will be there. Okay, I hope this one is clear. Okay, then I think one topic we left today yesterday, that was the postpartum hemorrhage. That was the postpartum. Antepartum hemorrhage we done, but the postpartum hemorrhage we left. Yeah, we did not do. So what is there? See now, a pregnant woman in her 40 week of pregnancy is now undergoing the obstetrics examination. The cervix of uterus is undeveloped. The oxytocin test is negative. The oxytocin test is negative. What does it mean? What does it mean? Oxytocin test means baby, the female is not under preparations, not in the contraction phase, not in the labor, not in labor. She is not in the labor. Examination at 32 weeks revealed AP is 140/90 mm, proteinuria is there, peripheral edemata is there, reflexes are normal. So choose the most correct tactics. So what we will do? We will do the labor stimulations after the preparation that we discussed. Okay, so in all these conditions, the final what we did? Finally, what we did there is a induction of the labor will be done. Therefore, the induction of the labor will be, if the mild preeclampsia condition, induction of the labor. Okay, here tell me, like we having the 140/90. Proteinuria is 1 gram. So 140/90, what is the answer? Less than mild preeclampsia or the severe preeclampsia? Mild. Yes, okay, that is the mild condition. So mild conditions, what we did in the mild conditions, we will monitor till the 37 weeks and the induction of the labors. Now see the lady when it's coming at the 40 weeks. So that's what we will do, labor stimulation after the preparations. After this question, which gestational age give the most accurate estimation of the weeks of the pregnancy by the uterine size? So that will be the less than 12 weeks. देखो इस कंडीशन में होता क्या है? Just give me 1 second. sorry. So which gestation age give the most accurate estimation of the week in the pregnancy by the uterine size? So that is the less than 12 weeks. I told you first trimester. Okay, so let's discuss it also. So देखो, whenever we talk like the best clinical assessment of gestational age, the best clinical assessment of the gestational age in mainly in the first trimesters. Mainly in the first trimesters, what is that? We having the fundal height, the fundal height. Okay, that is the best clinically if we do, and if we do the want to do the best overall assessment, and the overall assessments will be done by the that is the ultrasonography. So what happen if we talk about the fundal height? So fundal height, like for example, if this is my the uterus that is developing, so here we having the, so this at this one is the pubic symphysis. So this is the 12 weeks. And at the 12 weeks we see that there is a pubic symphysis will be there. This is what, that is the 16 weeks. And here what we are seeing, this will be like our umbilicus. थोड़ा ऊपर हो गया umbilicus, नीचे करते हैं इसको थोड़ा, ठीक है. तो ये हमारे पास क्या हो गया, umbilicus. Now umbilicus, remember कि umbilicus के अंदर आपको तीन याद रखने हैं. क्या तीन याद रखने हैं? Like this is my umbilicus. So at this point, यहाँ पे this one below one. So below one there will be write 20 weeks. Mid of that write the mid of that write the 22 weeks, and above of that write the 24 weeks. Okay, then if you take the distance 1/3 part, and this is 2/3 part, so 1/3 part, write it there. How many weeks? 28 weeks. Okay, 1/3. Again there is a 1/3, it becomes again short. Okay, write it like 1/3 and 1/3. Okay, so 1/3 it will be the, that is the 28 weeks. Then it will be again 4 weeks more, 42 weeks, and here we having the 36 weeks. And this is the jiffy sternum. This is what? This is the umbilicus. Regions. So fundal height, you need to remember, the fundal height will be at the pubic symphysis. So we call the, like we was discussing about the fundal height, period of amenorrhea. So the fundal height, if we see at 12 weeks, so at the 12 weeks we will see fundal height at the pubic symphysis. So palpable first time. So at the 12 weeks, the pubic symphysis, the fundal height will be palpable first times, and it then extending towards the abdomen, and they will enter into the abdomen after the 12 weeks. Like for example, if we talk at the 16 weeks, so 16 weeks it will be the midway between the, you can write it separately here also. I am writing it here, you can write separately. At 16 weeks, midway between the pubic symphysis and umbilicus. Will be there. Then at 20 weeks, it will be at the lower border of umbilicus. At 24 weeks, upper border of umbilicus will be at the 24 weeks. 28 weeks. At the 28 weeks, it will be junction of the 1/3 from the umbilicus and 2/3 from the jiffy sternum. At 32 weeks, 2/3 from the, So it become again 1 by 3, 1 by 3, 1 by 3. So 2/3 from the umbilicus, 1/3 from the G-sternum. 36 weeks it will be at the G-sternum. 36 week it will be at the G-sternums. What at the 40 weeks? Because we discussed now, normally we see the pregnant gestation period is 40 weeks. So at 40 weeks what happen? We having the G-sternums. Now the baby is the term baby. After the 37 weeks, the baby will become term. So baby, what are the fetus will start descending down. The fetus starts descending down. Fetus starts descending down. And when the fetus start descending down, this head will be go into the pelvic regions. So head will not be palpate. The head will be not be palpable. So in the questions you will get some kind of the questions that at the baby head is not palpable. So you understand, okay, he is talking about that baby is at which weeks? 40 weeks. At baby at the 40 weeks. So it will give the it will be the like same as the fundal height will be at same as 32 weeks. The fundal height will be same as 32 weeks. So what is that? The fundal height will be here at 40 weeks also. So at 32 weeks or at 40 weeks the fundal height will be the same. Okay. So now you need to, what you need to remember, देखो इसको याद रख लो कि remember the umbilicus point. The umbilicus point is what? 22. The umbilicus point is 22. Umbilicus point is 22. उसके ऊपर वाला above that 24, below that 20, between that decrease 4 16, decrease 4 12, increase 4 28, increase 4 32, increase 4 36. ठीक है, 28 32, increase 4 36, एक दो, above we having the 2, below we having just 1. That you need to remember. There is a 12 weeks after 16. Then umbilicus you need to remember 22. Umbilicus is what? 22. If you know the umbilicus, you can understand, okay, here we having the fetus. That is what the best assessment, the clinical assessment, and we measure with the help of the fundal height. And the best assessment is done by the, we having that the ultrasonography. The best assessment is done by the ultrasonography. Ultrasonography. Okay, I hope this is clear. And the fundal height is the best in first trimester. So the which gestation give the most accurate estimation of the week pregnancy by the uterine size. Uterine size, it means that saying trying to tell us about the fundal height, and the fundal height will be best give the most accurate, because after the 12 weeks it will not give the best accurate estimations. After that we having the crown rump length, biparietal diameter, that will be measured with the help of the ultrasound techniques. But if we can having the, it will, the fundal height will be most accurate till the 12 weeks, and the 12 weeks we can palpate the fetal head also, or we can palpate the fetal body also first times. Okay, that you need to remember. After that, question number 10. A 26-year-old woman had the second labor within the last 2 years with oxytocin application. So this is the second delivery within the last 2 years with the oxytocins. So they provide the oxytocin. The child weight is 4080. What we called it? The more than 4 kg. What we called it? Pediatric. What we called it? We discussed in pedia. क्या बोलेंगे हम इसको, बता दो बता दो. What we will call it? Overweighted. Wow, nice. Overweight तो है, but one terminology was there. Larger for gestations. Just tell me the one terminology. Something macro was there. Macro, micro, macrosomia, है ना. So what we called it the macrosomia. More than 4 kg baby, what we will call the macrosomia will be there. So after the placental birth there was the massive bleeding will be there. Massive bleeding. Oh, बहुत ज़्यादा bleeding. तो after the placental birth there were the massive bleeding. Sign of hemorrhagic shock also. Hemorrhagic shock के sign can you tell me? There will be the blood pressures will be decreased. There will be the tachycardia. Despite the injection of the gold contraction of the uterus and the absence of any cervical and vaginal disorder, the bleeding proceeds. कोई फर्क नहीं पड़ रहा किसका, contractive agents का, uterus good contract कर रहा है, still there is a no bleeding is there. Okay, तो choose the most probable cause of the bleeding. भैया गई क्या गई, uterus की tone गई. The atony of the uterus. A means absence. Tone means tone. यूट्रस कंप्लीटली रिलैक्स होके आनंद कर रहा है, घूम रहा है, एंजॉय कर रहा है. सो दैट इज द एटोनी ऑफ द यूट्रस, एंड दैट एटोनी ऑफ द यूट्रस इज द मोस्ट कॉमन कॉज ऑफ द पोस्टपार्टम हेमरेज. Okay, so let's discuss the topic that is the postpartum hemorrhage. Again, this is the important topic. Postpartum hemorrhage. Postpartum hemorrhage. देखो, in case when we talk about the postpartum hemorrhage, the postpartum hemorrhage, postpartum means that is after the delivery or after the abortion, that we call the post abortions. So there will be the excessive bleeding. You know Taj Mahal, ठीक है, सब जानते हो ताज महल. इन ताज महल इज ए मोन्यूमेंट ही बोलेंगे ना उसको, ठीक है. इट इज built by the Sahaja in the memory of Mumtaz, and Mumtaz was the 16th wife of the Sahaja, and she got died because of the which condition, which region, postpartum hemorrhage. तो देखो यहाँ पे तुम्हें हिस्ट्री भी सीखने को मिलेगा, है ना, तो ताकि तुम आगे जाके आईपीएस बन पाओ, ठीक है. सो that is the postpartum hemorrhage. So in postpartum hemorrhage, what is there? Excessive bleeding. There will be the excessive bleedings per vaginum. Excessive bleedings per vaginum after the delivery. And what is the criteria? Like after the delivery तो delivery के बाद तो मतलब 6 महीने, 8 महीने, 10 महीने, कितने? Up till the 12 weeks. It will be up till 12 weeks will be there. So excessive bleeding per vagina after the delivery and up till the 12 weeks. This is the most common cause of death. The most common cause of most rapid death in obstetrics. Rapid death in obstetrics. Okay. देखो नॉर्मली क्या होता है कि आफ्टर इफ इट नॉर्मली व्हाट हैपेंस दैट आफ्टर द नॉर्मल वेजाइनल डिलीवरी देयर विल बी द लॉस ऑफ द ब्लड. सो ओके, up to 500 ml is normal. So up to 500 ml is normal. In case of like if you having the cesarean sections, after the cesarean sections, so after the cesarean sections up to 1000 ml is normal. बट भैया अगर उसके बाद हुआ तो पोस्टपार्टम हो जाएगा, ठीक है. इफ मोर देन, सो दिस इज द नॉर्मल थिंग्स, दिस इज द नॉर्मल वन, बट मोर देन दिस कंडीशन, इफ मोर देन these, this it is known as the postpartum hemorrhage. If more than these, we call it as the postpartum hemorrhage. There is, according to the American Society, what it says that if more than 1000 ml of the blood loss, irrespective of the delivery, whether it is vaginal delivery, it is the cesarean, if more than 1000 ml is there, so we call it as the postpartum hemorrhage. So you need to remember this one, that is the normal vaginal delivery up to 500 ml normal, after cesarean section up to 1000 ml normal, if more than these value, postpartum hemorrhage, ठीक है. And there can be the sign or symptoms of with the sign, okay, write it here, with the sign and symptoms of hypovolemia. Okay, it can be the primary PPH. It can be the primary PPH or it can be the secondary PPH. It can be the primary PPH or it can be the secondary PPH. A primary PPH, or we can also call it as the early PPH. We can also call it the early PPH. And early PPH, it will be within the 24 hours. If it is occurring within the 24 hours after the delivery of baby, after delivery, so we call it as the primary. And secondary will be if it is occurring after the 24 hours up to 12 weeks after the delivery. So we called it as the late PPH or the secondary PPH. And this one is the most common. This one is the most common PPH, and the most common cause of this is what we having the question on that is the uterine atony. Uterine atony means uterine atony means tone of the uterus has been decreased. So tone of the uterus will be decreased or absent. The tone of the uterus will be decreased or absent. देखो, uterus now it does not contract properly. Uterus will not contract properly. If uterus will not contract properly, so there will be the normal. Let's see this. Now what happen when we having the babies delivering? After the baby, the placenta has to be delivered. When everything is done, then uterus, they having the property of atony. They having the contraction property. And when the uterus will contract, there is some living ligature. I told you there is some uterine artery and all the spiral artery and all those artery. They are going to the placenta and they are traveling here and there. They are leaking out. They are leaking out the bloods. As we discussed, there is the normal vaginal bleeding 500 ml and normal cesarean delivery is 1000 ml. But once the everything has been done, pregnancy has been done, placenta has been out. So after that, the uterus is there, and the uterus, when it will try to contract, so when they try to contract, there will be the blood vessels will be there, and these blood vessels, when the uterus will contract, they will be like the stop, or there is some stoppage will be there. Stoppage will occur there. We call this condition as the living ligature of the uterus. Living ligature. Ligature means something has been stapled. Something has been stapled. So we call it as the living ligature of the uterus. Okay. So in this condition, what we are seeing, the uterus is not contracting properly. So the living ligature will be absent. Living ligatures will be absent. So the living ligatures will be absent in this condition. The living ligatures will be absent in this condition. So we call this condition as the uterine atony. What is the cause? Whatever the cause of uterine atony will be the cause of the postmortem hemorrhage also. The causes of uterine atony. So remember, we having the polyhydramnios. What is the polyhydramnios? More amniotic fluids. The more amniotic fluids will be there. Then multifetal pregnancy. Multifetal pregnancy means if more than one fetus is there. Dizygotic twin, monozygotic twins means twins are there. So or macrosomia, if the fetus weight is more, macrosomia is there. So now you see, if there is a polyhydramnios, multifetal pregnancy or macrosomia, the uterus will be big in the size. Uterus will be increased in the size, and the uterus will be increased in the size. There is the overstretching of the uterus. We called it the overstretching. Normally, when you do the gym or all these activities, and you make the bundles, you're making your biceps, triceps, or you having some fat tissue, you see some fatty persons, and after the he go to the gym and he maintain his body, so then you see there is a some muscle striae is there. This is due to overstretchings of the body that has been developed when he was fat. The overstretching of the body will cause the stria. So if the polyhydramnios, multifetal pregnancy and macrosomia is there, so in that conditions what we do, overstretchings of the uterus will be done. Overstretchings of the uterus will be done, and what the overstretchings will do, will decrease the tone of the uterus. So now you understand why it is the cause of the uterine atomy. There is other cause also, like if there is a grand multipara. ग्रैंड मल्टीपैरा में क्या था, 4+1. ग्रेट ग्रैंड मल्टीपैरा में क्या था, 9+1. ठीक है. और इफ देयर इज ए प्रोलॉन्ग्ड लेबर, यार काफी लंबे टाइम तक, अभी देखो नाउ फॉर एग्जांपल वी आर स्टडिंग एंड इफ आई विल स्ट्रेच दिस टाइम टिल एटलीस्ट मिनिमम, if I will teach you till the morning, so what you will do, it will become the prolonged, like after the 2 or half an hour it will be prolonged for you. ठीक है, तुम्हारे लिए तो ज्यादा ही हो जाएगा वो भी. तो अभी मान लो, अभी you will see there will be the, your tone will be decreased, your energy will be lost, everything will be lost. If the prolonged labor also, the everything will be decreased in these conditions. और the labor will precipitate. labor रुक गया है, कह रहा है मैं अब होऊंगा, मतलब कॉन्ट्रैक्ट ही नहीं करना चाह रहा. वाई कॉन्ट्रैक्ट, अब वो काफी देर से वहीं पे रुका हुआ है, कोई कॉन्ट्रैक्शन ही नहीं हो रहा. यूट्रस सब कर रहे हैं पुश पुश पुश, बट नो पुश, only pull pull. So on conditions there will be the, what we see, the precipitate labor. So all these conditions what we are seeing, there the uterus tone is gone. So what will be there, there will be the decreased tone will be seen, and the tone will be gone means that there will be the atony of the uterus will be there. Okay. The other thing also, like for example, as the question is there, so they can ask you this one also, the uterine fibroid also, because uterine fibroid also increases if there is a like increase the surface area of the uterus, then again there will be the overstretchings can be there. and one more thing that is the common for that we are keep seeing, that the history of the PPH is there. So in that further lady there can be the history of the, जैसे for example देखो multi gravida we discussed ना, grand multipara, great grand multipara, who was that, मुमताज, ताज महल. ठीक है, तो उसमें भी क्या हुआ, ग्रेट ग्रैंड मल्टीपैरा का भी ग्रेट हो गया. तो दैट वाई दिट विल कम the decrease in the tone of the uterus, and then she will be having, she got many multiple oxytocins and all those things, but then still she did not recover. And that's why we discussed also that is the most common rapid cause of the obstetrics, rapid death of the obstetrics. Then there is a next one is the secondary PPH. The next one is the secondary PPH. Okay, let's first do the question. So here you can see that there is a macrosemic baby, the placental birth, there were the massive bleeding, means there will be the, which one, PPH, postpartum hemorrhage is there. Hemorrhagic shock, yes, there can be the hemorrhagic shocks, the BP decreasing, tachycardia, all these things can be there. Despite the injection of the contraceptive agent, good contraction of the uterus, absence of any cervical vaginal disorder, the bleedings proceeds. So choose the most probable cause of the bleedings. What is the most common cause of the primary hemorrhage, that is the atony of the uterus will be there. Okay, hysterodoxis, that we will discuss, that is the rupture of uterus. The hysterodoxis, that is the rupture of uterus, that we will discuss, and I will tell you the symptoms, that then you will be able to understand. There is nothing hypotony of the uterus, no, because I told you that is the primary PPH, and the primary PPH, the most common cause is the atony. Then there is a secondary PPH. The secondary PPH, the most common cause is the retained placenta. Most common cause is the retained placenta. The most probably they will ask you the primary PPH because that is the most common. The secondary PPH is the rarely seen, but if the placenta is retained inside, so that is the become the most common cause. Other common cause, that can be the trauma, like the perineal tears or the coagulation disturbance. So the first management we will do, In this condition, that we will do the resuscitation. So first we will do to prevent, because this patient is under the shock, so we will prevent the shock first, and we will give the injections, that IV tranexamic acid. Okay, that you need to remember. Okay, is this clear till now? देखो, there are the multiple drugs we can give in here, but the management, again I'm not telling you because this is not for our regions. ठीक है, the most you can understand here one thing also, that if we will palpate the uterus and if it not palpable, so means that is the case of the uterine atony also. Okay, so if you are palpating the uterus, if palpating the uterus and the uterus is not palpable, if uterus not palpable, so the uterus not palpable, we will call it as the uterine atony. ठीक है, बता दो मुझको, नहीं मैं आगे चलूं. Okay, is that correct? Macrosomia. Okay, so let's continue. ठीक है, so this one you need to understand about the primary PPH and the secondary PPH. So let's discuss the hysteroraxis, because this is again the next question. So let's discuss here the hysteroraxis also. The hysteroraxis. देखो, in case of the hysteroraxis, we call as the uterine rupture. So there is a two conditions that we will discuss now. There is a one condition that we having, that is the uterine dehiscence, and there is another condition that we call the uterine rupture. So the both are the like quite similar things, but there is a light little difference between them. So that we will discuss. So one is the uterine ruptures, and so before that we are having the uterine dehiscence. Uterine dehiscence. Okay, so this is what, this is the conditions like before the uterine ruptures. Discuss the uterine dehiscence. So in uterine dehiscence, it is the conditions like the impending, we can also call it the impending ruptures, we can also call the impending rupture. What is the meaning of impending? मतलब uterus का rupture होने वाला है, तो impending rupture means uterus may rupture, uterus may rupture, that is uterine dehiscence. So in case of the uterine dehiscence, or impending rupture, the serosa is not involved, or serosa is not rupture. The serosa is not rupture, or we can say the serosa is, it will be the intact. The serosa will be, or you can write it here, the serosa is intact. Directly in simple terms, the serosa is what? The serosa is intact. The serosa does not rupture. And in this condition like hysteroraxis, the serosa will be rupture. The serosa will rupture. Serosa, we know that the outer covering, the serosa, so here in this condition the serosa will rupture. The serosa will rupture in these conditions. What are the symptoms or the sign we will see in this condition? So whenever the uterine dehiscence will be there, so there will be the scar formation. So we will see there is a pain in that scar regions. Pain in that scar regions will be there, and we will see the some sign also. The some sign we can see that the most consistent sign will be the fetal tachycardia. The most consistent sign we will see in this condition, that will be the fetal tachycardia. And there will be the tenderness. Where we will see the tenderness? We will see the tenderness, or dehiscence we can say the uterine scar also. The dehiscence we can also say the uterine scar also. This is the scar, tenderness will be seen, and there is we see the mild bleeding per vaginal. We will see the mild bleedings per vaginal, and there will be the mild hematuria will be there. The mild bleeding per vaginal, mild hematuria will be there, and the management what we will do the immediate cesarean sections. The management what we will do, immediate cesarean sections will be done. Okay, in case of the uterine rupture or hysterorexis, the serosa will be ruptured. So what are the signs we will see in this condition? The sign that we will see in this condition, there will be the fetal bradycardia. There will be the fetal bradycardia will be there. Okay, I'm writing it here so that it will be easy. What are the signs we will see? That we will see the fetal bradycardia will be there. In case of the uterine dehiscence, we see there is a fetal tachycardia is there. But in case of the uterine rupture, I hope you all know what is the uterine rupture. If the rupture is there, then the massive bleeding will be there. When the massive bleeding will be there, BP will be reduced, and there can be the tachycardia. But remember here the signs we having, what we see, the fetal bradycardia, because fetal is having the hypoxia problem, and due to which the female will the fetus will be having the problem with the bradycardia. Then remember, in these conditions we can palpate. The fetus parts can be palpated. The fetus parts can be palpated superficially. The fetus parts can be palpated superficially. Now we will when we are having the uterine rupture, so this the fluid formations will be there, the fluid accumulation will be there, and this free fluid will be accumulated in the peritoneal cavity. The free fluids will be seen in case of peritoneal cavity will be there. Here we see the mild bleeding. In case of uterine rupture, we see the profuse or the massive bleedings, or we also see there is profuse bleedings per vaginals, and we also seeing the profuse hematuria. Okay. So what the management we will do? The management will be done, that is the try to repair the uterus. So what we will do? Immediate laparotomy. Immediate laparotomy will be done. If this is like immediate laparotomy will be not successful, then we can do the total abdominal hysterectomy. We will cut the abdomen and we will remove the whole uterus out. So that is the total abdominal hysterectomy. Okay. So this was the hysteroaxis. A woman is admitted to the maternity home with the discontinued labor activity, slightly bloody discharge from the vagina. Slightly bloody discharge. There is a slightly bloody discharge from the vagina. The condition is severe. The skin is pale. Consciousness is confused. The BP is 80 by heartbeat of the fetus is not higher. There was a cesarean section years ago. Could you please determine the diagnosis? So you can see there is a slight bloody discharge. As in this question they are not giving the profuse bloody, so don't confuse with that term. Okay, the condition is the severe. There is a discontinued labor activity. Along with that, you are giving the history of the cesarean sections. So they all are the risk factors. The cesarean section are the risk factor because of the cesarean section there can be the scar formation. Yes, because of the cesarean section we can see there is a scar formation, and this scar will having the impendage or having the tendency to rupture. Scar having the tendency to rupture. The condition is severe, the skin is pale, consciousness, BP is decreasing. So they all are the hypovolemic features we see, and heartbeat of the fetus is not here. So this means fetus is died. And could you please determine the diagnosis? So what will be your diagnosis? That will be the hysterorexis will be there. Okay. So all these symptoms you need to remember. If you are getting the fetal bradycardia, fetal parts can be palpated, the free fluids in the peritoneal cavity, profuse bleedings, or it can be the mild bleedings. So don't confuse with that. But normally we will see there is a bleeding will be high if there is a complete bleeding or more uterine ruptures will be there, and profuse hematuria will be there. So don't confuse with this type of the term because these are the translated questions, है ना. So they can give the slight or they can having the same meaning of that. They will not give you the proper informations, but their meaning, their intention is what, that they wanted कि you should read this as the profuse bleeding. Okay, so that will be hysteroraxis. And I think there is no questions about the uterine dehiscence and the uterine rupture. So you need to understand that there is a uterine rupture for the CROC 2 point of view. You need to understand uterine dehiscence or uterine rupture is the same things. I will not tell anyone, but you need to remember these things. ठीक है. So remember that are the both are the same, क्योंकि दोनों में इतना ज़्यादा फर्क है नहीं. ठीक है, because they will not give you the differentiation. If by chance they will give you that both in the option, then you can easily able to separate those things and you can easily make the answer based on these findings. But most probably they will not give you this. They will give you either uterine rupture or they will give you hysteroraxis in the options. ठीक है. What are the cord presentations, placental presentations, that we will discuss later on. Okay, but I was telling today more. Did I discuss with you filamentous insertion of the cord, where we discuss the placenta previa, brachioplacenta, antepartum hemorrhage? नहीं किया ना, वो नहीं किया ना. तो अगर वहाँ पे जगह, if you have the space between the placenta previa and placenta brachio, तो write there filamentous insertions of the cords. अभी फिनिश ही कर देंगे इसके बाद ना, जस्ट वी विल फिनिश इट. ठीक है. Just study these topics and then we will finish. The filamentous insertions of the umbilical cords. Show you this one. Here if you having the space like between these things, so we discussed about the, let's repeat it once again, the antepartum hemorrhage. So in the antepartum hemorrhage we discussed that the bleeding from into the genital tract after the age of viability or before the delivery of the baby, we called it the antepartum hemorrhage. The most common cause, that is the abruptio placenta, placenta previa, vasa previa, that we will discuss today. Now preterm labor we discuss and the uterine rupture we also discuss. So all these topics we discuss. The placenta previa, you know what we call the placenta previa. If lower edge of the placenta is touching or covering the internal os, low lying placenta, if the lower edge within the 2 centimeter, if the low lying placenta, if there we have the lower edge of placenta within the 2 centimeter and further it covering the internal os, we call the low lying placenta will become the placenta previa. Okay, so you can understand this is the both the same things, but the new as the difference of the terminology only. There is a history of the placenta previa, twins, smoking, the bleeding per vaginal, the recurrent bleeding, fresh blood will be there, the massive blood will be there, the painless, usually followed by the small warning hemorrhage. Signs we see the per abdominal examination, abdomen, uterus, soft, relaxed, non-tender, the fetal parts will be palpable, the fetal sounds will be hearable. Fundal height will be equal to the period of amenorrhea. The most common malpresentation in the placenta previa will be the transverse lie. ठीक है. The most common malpresentation in the placenta. We will discuss what is the transverse lie, longitudinal lie. ठीक है. For now, just remember the most common malpresentation, if they will ask you in the placenta previa, that will be the transverse lie will be there. Abruptio placenta. There will be the premature separation of the placenta and the most common risk factor, abruptio placentae. Hypertension, stoma, concealed, the lower edge of placenta is intact, lower edge of placenta is separated, initially concealed but later revealed, mixed type. ठीक है. Now you understand what is the fundal height. The fundal height more than the period of the gestations. more than the period of amenorrhea. If the fundal height is more, that is the concealed variety, that will be the concealed. Due to accumulation of the retroplacental blood, the fundal height will be increased. Here there is a no accumulation, so there is a no fundal height will be equal to the period of amenorrhea. Investigations will clinically correlate. Others we can do the ultrasounds. Then we have the premature rupture of membrane, preterm labor rupture of membrane. If the rupture of membrane occur after 37 weeks before the labor begins, PROM. The rupture of membrane less than 37 weeks of pregnancy, we call it the PPROMs. The rupture of risk factors, we'll see the previous history of the PROM, PPROM, and these infections can be there. Abruptio placenta can be there. The woman present with the history of the sudden gush of the fluid from the vagina, clear pale yellow, alkaline pH, and if you will see the alkaline pH, we can do the nitrogen paper test like a litmus paper. If it turns blue, alkaline fluids will be there, amniotic fluid is there, and we can understand this is the PROMs. The outcome, cord prolapse, malpresentations, so these all we discussed. Now let's discuss about the filamentous insertions of cord. And also write one more things on this page, write this page only. Write it here in anything. The placenta previa. The placenta previa, what they will cause? They will cause mainly the antepartum hemorrhage. They mainly cause the antepartum hemorrhage. But if we talk about the abruptio placentae, they can be the reason of the postpartum hemorrhage. No, not the placenta. No, that both will cause the antepartum hemorrhage. There is one more terminology that we call the placenta accreta. The placenta accreta. Okay, placenta accreta means when the placenta is morbidly adherent, so that is the cause of the postpartum hemorrhage. Okay, so don't confuse between the placenta previa and placenta accreta. The placenta accreta is the cause of the postpartum hemorrhage. The placenta accreta, I hope this is the morbidly adherent placenta. थोड़ा थोड़ा placenta अंदर मतलब एकदम से चिपका हुआ है. तो now you understand why it will cause the PPH. ठीक है, because जैसे ही placenta आएगा उसके साथ साथ ये भी आ जाएगा, तो it will cause the heavy bleedings. So that's why it will become the cause of the postpartum hemorrhage. It's not the placenta previa and the AP both cause the antepartum, and placenta accreta cause the postpartum hemorrhage. The filamentous insertions of the umbilical cord. देखो, we studied about the placenta. We studied that there is a fetus is there. We studied there is a placenta is there, and we studied that there is a something chorion and amnion. This is the fetal membrane we discussed. There is some fetal membrane, and umbilicus we studied that this is attached to the placenta directly. But what happen if this if this umbilical cord it attached to the fetal membrane? So it becomes the filamentous insertion of the cord. When the umbilical cord inserted on fetal membrane, when the umbilical cord inserted on the fetal membrane, so we like amnion and chorion, the amnion and chorion. When the umbilical cord will inserted on the fetal membrane, amnion and chorion, so we will call this filamentous insertion of the umbilical cord. Now firstly this umbilical cord it is attached to the amnion and the chorion, and then it will traverse the membrane and will reach to the placenta. Then will traverse the membrane and reach placenta and reach the placenta. The complications, what are the complications we see? The complications we see in these conditions, that is the vasa previa. The complications we see in these conditions, that is the vasa previa. What is the vasa previa? We called it as the previa of umbilical cord. The previa of umbilical cord. Previa of the umbilical cords. Okay, so here in this also, in this condition also, we see the bleedings per vaginal, and the bleedings will be fresh bloods, or that will be the fetal bloods. The fresh blood, that will be the fetal blood will be theirs. The fetal bloods. Can you tell me what is the previa of umbilical cord, vasa previa? If you understand the concept of the placenta previa, can you tell me what is that? No भैया, नहीं बता सकते यार. नो, what is the placenta previa? ठीक है, what is the placenta previa? we, we almost finished the class. ठीक है, what is the placenta previa? The placenta is, questions once again, lower edge touching the internal os. Placenta cover the, question is, can you tell me what is the, or see the question, what is the previa of the umbilical cords? Previa of the umbilical cords. यार वो, there, that was the previa of placenta. ये क्या है? Previa of umbilical cord. This is what previa of umbilical cord. So now tell me, if in previa of placenta, the placenta is touching the internal os. In this case, umbilical cord is directly touching the internal os, na? So simply, what is that? Vasa previa. If this umbilical cord is there and we, it is covering the internal os, it is lying the, it is lying near the, it is lying near the umbilical cords, and then it is inserting into the, then it is inserting where? Into the placenta. So if it is, this is called the placenta. This is the previa of umbilical cord. Plus previa means low lying place, low lying things. So low lying umbilical cord here. In previa there is a low lying placenta. Here in umbilical cord there is a low lying umbilical cord. That's why we call it the previa of the umbilical cord. Simple. कितना easy है ना? Lower edge is touching the os. Lower edge of umbilical cord. Your umbilical cord is touching the internal os. Then how you will differentiate? How you will differentiate maternal blood and maternal and fetal bloods? How you will differentiate the maternal and fetal bloods? Which test? So that is the Singer's alkali denaturation test. So there is a one question, I think, in your base or in the previous year paper, that is the singles alkali denaturation test will be there, or we also call this test as the APT test. We also call it as the APP test. So this test can't diagnose the can't diagnose the vasa previa. They can't diagnose the vasa previa. That, remember this, just remember this line. It can't diagnose the vasa previa, and this single alkali denaturation test, it differentiate the maternal and the fetal bloods. And the reagents we will take, that is the 10% potassium hydroxides, or if not available we can take the 10% sodium hydroxides. And but the, also remember, this is like the basics things that you need to remember, that hemoglobin F is resistant to alkali. This is the one liner questions. Hemoglobin F is resistant to alkali. If the hemoglobin F is resistant to the alkali, so fetal blood is not denatured and the maternal blood will be denatured. Okay, so that you need to remember, that what the, and also remember, what if the vasa previa is developed, so management what we will do, directly we will do the cesarean sections. We will do the cesarean section. The management will be done, that is the cesarean section. Okay, is that clear? Okay, so this is for the today, and rest we will do tomorrow. And after that, I think you will have the 2 day holiday, because I'm going to the councils, so that's why. And so I will go, I think, tomorrow if, at night times, and I will reach here at the next night time. Maybe one day holiday or 2 day holiday, we will see. But you will having, so those who have not finished the previous ones, finish that. And maybe tomorrow do we have any class, so we can have the class in the I think before the 6 p.m. Is that possible? ठीक है. In APT test, was blood nature's baby or mother's? In APT test, the hemoglobin is resistance to the alkali, so the mother's maternal bloods will be denatured. Maternal blood will be denatured. Fetal bloods will be resistant. The fetal blood is resistant to the alkali, so that's why it will not be denatured. But maternal blood is not resistant to the alkali, so that's why it will be denatured. Okay. The quality of what you do is more important than the quantity. Okay, so understand the topic is the biggest things. Okay, this is the task for the today, or you quote for the today, that whatever you are doing, remember the quality is always the important things than the quantity. Quantity, yes, you need to do the questions, but what if the similar questions you will keep doing without any knowing the concept. So basically focus mainly on the concept, how bleeding happens. भाई इन प्राइमरी पीपीएच के अंदर क्या होता है कि जो यूट्राइन एटोनी होती है, देखो यूट्राइन एटोनी जो होती है, यानी कि टोन ऑफ द यूट्रस जो है ना, वो डिक्रीज हो जाती है. अब देखो अगर मैं तुम्हारी भी टोन डिक्रीज अगर कर दूं, ठीक है, अगर तुम्हारी बॉडी बिल्कुल मसल्स जो है, मसल्स टोन बिल्कुल डिक्रीज हो जाए, तो वो क्या हो जाएंगे, एकदम से फ्लोपी टाइप के बन जाओगे तुम, है ना. तो इसी तरीके से क्या होता है कि यूट्रस जो होता है, तो उसकी जो कॉन्ट्रैक्शन है, जब यूट्रस कॉन्ट्रैक्ट करता है, तो यूट्रस जब कॉन्ट्रैक्ट करता है ना, तो बहुत सारी जो वेसल्स है ना, उनको लाइगेट कर देता है, मतलब उनको एक प्रकार से उन पे प्लग मार देता है कि तुम बंद हो जाओ, स्टेपल कर देगा उन सभी उन्हीं ब्लड वेसल्स को. अब वो ब्लड वेसल्स जब स्टेपल हो जाएंगी तो ब्लीडिंग रुक जाएगी. तो दैट्स वाई द यूट्राइस कॉन्ट्रैक्शन होना बहुत जरूरी है. बट इन केस ऑफ द एटोनी ऑफ द यूट्रस, जो यूट्राइन की कॉन्ट्रैक्शन है वो बिल्कुल अब्सेंट हो जाती है, तो यूट्रस क्या हो जाएगा, कंप्लीटली रिलैक्स हो जाएगा. और यूट्राइस अगर, जब भी तो हम क्या देते हैं, ऑक्सीटोसिन देते हैं ना. ऑक्सीटोसिन क्यों देते हैं एट द टाइम ऑफ द लेबर, ताकि यूट्रस कॉन्ट्रैक्ट करे, ताकि मतलब जैसे डिलीवरी हो जाए, प्लेसेंटा भी आउट हो जाए, और प्लेसेंटा के बाद यूट्राइस कॉन्ट्रैक्शन, लाइगेचर जो है यूट्रस का, जो ब्लड वेसल्स लाइगेशन है, उनका लाइगेशन हो जाए, वो उनकी ब्लीडिंग बंद हो जाए. ठीक है, दैट्स व्हाई वी गिव. सो इसकी वजह से क्या होगा, अगर यूट्रस में एटोनी है, तो वो क्या कर देगा, प्राइमरी पीपीएच का कोज होता है. जैसे फॉर एग्जांपल अभी हमने क्या पढ़ा कि मैक्रोसोमिया का कंडीशन है, या फिर मल्टीपल प्रेगनेंसी की कंडीशन है, तो वो क्या कर देंगे, एकदम ओवर स्ट्रेच कर देंगी. ठीक है, यूट्रस को पूरा ओवर स्ट्रेच हो जाएगा. अब जब यूट्रस ओवर स्ट्रेच हो जाएगा, तो यूट्रस ओवर स्ट्रेचिंग की वजह से जो उसकी टोन थी, तो वो तो क्या होगी, डिक्रीज हो जाएगी. अब उस टोन की डिक्रीज की वजह से क्या होगा, पीपीएच हो जाएगा. ठीक है, द सेम थिंग दैट वी डिस्कस्ड इन इंग्लिश आई एक्सप्लेन इन हिंदी. ठीक है. Okay, so see you tomorrow. Bye bye, good night, and please keep revising everything again and again. Okay, good night.